She also serves as the local course director for the Advanced Pediatric Life Support Program, Australia. She maintains strong connections with the thalassemia community in Maldives and is a vocal advocate for high-quality care for thalassemia patients. Additionally, she is deeply involved in raising awareness about congenital heart disease and other cardiac conditions. The topic for today's session by Dr. Eleena is First Critical Congenital Heart Defect Repair in Maldives, Coarctation of Aorta. The floor is yours, Dr. Eleena.
Thank you so much, Dr. Shiza, for that beautiful introduction. She has always been an inspiration to me. Thank you. Bismillahirrahmanirrahim, and a very good morning. I would like to thank Theveli for being the Theveli for me. And actually, when Dr. Shiza introduced the topic, I would like to say that I've changed it a bit because then only it becomes the Theveli for the people who is here. And I think this is the forum, which is the ideal forum for it, actually. So I'll be looking into congenital heart disease, the pediatric heart disease as a whole in Maldives. So being the only pediatric cardiologist in the country, I feel that I have this privilege, and then it is with the teamwork that we can build on research. And then I want to see the boundaries that we have in the field of medicine, because a lot of data, you can say, you can say that none of the data is available for us, and then it should be made available, and research should be done. So when I try to look at the data on Maldivian population, this is what I found recently, actually. So this was the statistics which was published last, and then it is given as the total population as 3,44,000, with the population in 2022 of 382,751 people. So when we look at the births, maximum of which is in the center that I'm working, the IGMH, of course, but it has been distributed to the main hospitals in the Mali region now, with Treetop and the ADK taking a lead too with it. So we have a total birth of, in 2020, 6,293 births. And in 2021, it's 5,914. So with this, I would like to say that we have an integrated database, a regional integrated database for newborn birth defects, actually. So the data on birth defects are being entered actually regularly to see how much birth defects is in the country. So the types of birth defects, if you look at it, some of the data, it's a bit old because I have not been able to analyze everything. And this is, again, an area that we need to see, because a lot of data is available on it. So if you look at this, we can see that the majority of the chunk, the children actually suffer in the birth defect, in the birth defect region is thank you, is in the heart, actually. So the pediatric heart is an important region of the body that we have to concentrate on. So almost 1/4, actually, say more than 1/4 is because of birth defects in the heart. So we should all realize that it's a lot of work we need to put in this. Why is this happening? I do not know. Why does this happen so common in Maldives? It is the same as the all over in the region. When I look at my data roughly, I found that it is higher, actually. So in our small community, why is it so high? So these are things that we should look into. If you look at the birth defects, it's a lot of birth defects are there, but of course the complex congenital heart disease is the maximum again in the data. But these are just rough data that I have taken from the work that I have done. In 2018, that is after I've come back from my studies in 2015 as a cardiologist. I was practicing as a pediatrician before, of course. And I found out it was very painful for me to see children coming from the islands, actually, and then dying in the ER. Why? Because these birth defects are not detected. So they suffer. So we had a workshop where these can be screened actually. So in 2018, we brought everyone together from the regional hospitals, from the Mala region hospitals, from everywhere. And then we had a workshop to simply find these children who are having these defects. So this work has been going on. But is it being done well? I do not know, actually. So there was a thing that we used where I studied in the institution that I studied. Of course, this is in Thai. I studied in Bangkok. So this wheel, a simple wheel, was used to detect these children with heart disease. And then my mentor, who was the head of cardiology then, he has actually translated it for us and then brought up to be used in the Maldives, actually. So this is also available, and it can easily be done. And it is just a few minutes of your work during the day. And then this, I have been able to, actually, with the team support, Dr. Nyasha being the head when I came in the Department of Child Health, where I am today. She was a beautiful mentor. And with this, I was able to make a guide, and then it's published as a national protocol now, which is available for all of us online. So in IGMH, we have a congenital heart disease screening form, which is there, and then all babies has to be screened before they are discharged from the hospital. There are multiple anomalies which can occur in the heart, many things, not the usual that you see. The baby looks beautiful or normal outside, but of course, he might be having a very critical condition in his heart. And the mother, the father, who's expectantly waiting for their first child would not know. In 3 days, they usually come up and can die if they have a hyperplastic left heart syndrome, a tetralogy follow, critical, pulmonary atresia, tricuspid atresia, TGS, or total anomalous pulmonary venous drainage, and many conditions can be there, which we have here in the Maldives. So we targeted some of the 7 main lesions to detect, because these are the children who can die suddenly when they come up, when they are sent home without being detected. So with this, again, some of the old data, of course, when we come back from studies, we are very energetic. And I believe in research. I'm somebody who loves research. And I've collected a lot of data, and I was being able to analyze a bit of it, actually. So these are not published, by the way. These are just data from the Eco Lab and the work that we've done. So being in the tertiary center, I'm being able to actually say that 90% of the babies would be reaching us in. And then being an only person in the country, I am privileged and lucky to see these babies even in ADK or even in the treetop or wherever they'll end up in. So everything is pulled up, and these are the conditions that we have and how the number of children who are suffering from congenital heart disease in the Maldives up to February of 2018. And then this is the forum where I am so happy to see the students here. You can actually look up the data and then see how this is going in the Maldives. And is it increasing or in a decreasing trend? Or how is it? Why is this happening? The normal heart, it's a very complex structure, a beautiful structure. And this is how it looks when it is nicely normally formed, and then you do not have any problems. Intrauterine, when the baby is inside the womb, the baby doesn't have any problems because the mother is everything. Mother is everything. So the mother provides the oxygen for the baby. But when they are born, it's not the same. They suffer because the mother is not there, and the oxygen would not be provided, and they are not being able to maintain the circulation when the mom is not there. So some of the conditions I just thought that we have common in our population. Pulmonary atresia, a lot of children are suffering. I have seen children die out of it when I came initially. Pulmonary atresia is a condition where the main vessel of the body, that's the pulmonary artery, which actually pumps out the impure blood in the body, which comes to the right heart, right atrium and right ventricle. It gets out to the lungs through the pulmonary artery. So this pulmonary atresia children doesn't have that pulmonary artery when they are born. So intrauterine, they don't have any problem because the mother is maintaining their circulation. The placenta is the lungs. But it's not the cause when the baby is born. So they die, usually if we do not detect these children in 3 days. But these children can have a normal lifespan if we detect it immediately after birth, they can have a lifespan of 50 to 60 years without having much difficulties. So these are children that we can prevent from suffering. The tricuspid atresia is another condition that we see in our population. Lateral fellow, the most common, I would say, in our society, in our congenital heart disease group. Of course, we have a lot of them actually doing their A levels. We have a lot of them actually in their adolescence and the adults age group too. So this actually shows that if we can detect them in time, they can have a normal life. Actually, I always take up the example of for them, because these children would cry in my OPD, saying that whether they can play sports. And there is one American who is actually a world champion in snowboarding. He is one of the boys who was born in with tetralogy fellow heart. So I always take up that example for them. So that is how a normal life they can live. We have a lot of children with total anomalous pulmonary venous connection. So the oxygenated blood gets deviated to the right heart again after being oxygenated. So that means the deoxygenated blood and the oxygenated blood again mixes. TGAs, we have children who are doing very excellently well. So with a beautiful hand, I would say that I am, by the way, a physician, a pediatric cardiologist. And of course, we work as a team with the pediatric cardiothoracic team. And then if the child has a good surgery, with a good surgeon, the child can have a normal life again without any difficulties. Truncus arteriosus, we have many children with it. Hypoplastic left heart being rare, of course, that is very common in our community too. I do not know why. These are things that we have to explore. Currently, when I'm speaking, there is one child in our ICU with the condition, who was born 3 days back with hypoplastic left heart syndrome. So with this, who are we screening? We screen all the children who are born, actually, every single one of them. So we screen the newborns who are 24 to 48. So after 1 day, ideally at 2 days, they should be screened, actually. The closer to 2 days, the better, 48 hours, because there is a detection rate of very high detection rate if you can screen that time. So, but IGMH being the tertiary center, again, we are very scarce of bed. So we have to discharge them so fast, actually. So because of that, I think some of our children will go missed because it would come as a false negative sometimes. So this is a simple test which measures the oxygen saturation of the blood. So it's non-invasive, it's painless, it's very accurate. If you look up into the studies, we do not have the Eleena of Maldives, of course. It's fast and it's easily available to perform, and it's inexpensive. It can be done anywhere, in any of the birthing centers. And this should be done, actually, as a complement to physical examination, of course, we know. So because we should always examine the baby. Contrary to the rest of the newborn screening panel, which is invasive also, this interpretation, and then we do not have to wait for the result, because it would be immediate. You are the one who is going to discharge the baby. You are the one who is going to decide whether he's going to stay here or he's going to go home, whether he's going to, or the condition in the heart is missed or not. We would be deciding before we discharge the baby. And it's just a simple equipment. But it's really sad to say that in many of the islands, we still lack it. I do not know why again. But it's a simple equipment, and then it can be used even in all the birthing centers. But we do not have pediatric probes still in the islands. So it should be done in a quiet area. We should attempt to perform the pulse oximetry on an infant while the baby is not crying, because it's impossible. The students should remember, it sounds very simple to measure the saturation. You should try yourself, actually. So once you start doing it, then you will understand the challenges. But it can be done easily when you are an expert in doing it. Our nurses are beautiful experts, I would say. Our pediatric nurses and ICU nurses, but everyone should be able to do this. And then we would be making sure that the infant's right hand, and of course the feet, they are clean, because post-negative can come with it if there is dried blood or if there is some contamination. So this is the place that the probe would be placed. And then we read these records, and if it is abnormal, we have a protocol that we follow. So the majority of the probes that we have in the ICU are disposable ones, and this is how it is applied. So we check the pulse oximetry at 24 to 48 hours of life, and shortly before discharge, if the if the baby is being discharged before 24 hours. And when medically, of course, appropriate, if the baby is in the NICU. Many of our babies go to the NICU, actually. So let's say that the initial pulse oximetry reading is abnormal. What do we do? For all of us, when we are born, we have to have an oxygen saturation of 95 above. So let's say that the baby has a saturation of 90 to 94% in his right hand or foot, or if there is a difference between the saturation of the upper limb and lower limb, we need to repeat this pulse oximetry in 1 hour. We do not discharge the baby. We keep them in. Again, let's say that we do that again after 1 hour. What happens to the baby? Again, if it comes as negative, we repeat the pulse oximetry in, again, 1 hour. And then still, if the third one is fails, you do not discharge the baby. You inform the on-call pediatrician, and a certain protocol has to be followed. So it's a very simple algorithm that you have to follow. So this can be done for all the babies in the whole country, actually, not in IGMH only, everywhere. So a failed screening, child would not be going home. So the on-call pediatrician would be notified. And of course, they would end up calling me or somebody who is well-versed in doing a pediatric echocardiography. Some of our adult colleagues are very good in it. When I'm not around, they are the helper for me. We work as a beautiful team. So they would be notified, and that maybe would have an immediate echocardiogram to identify why the child is having an abnormal saturation. So this is only the data that I have, I'm sorry to say, because I have not been able to analyze. But this data should be there in IGMH. This should be looked into. Is everybody being screened? Because when I initially started it, when I looked into it in 2018 and 2019, we had 2,044 children screened in IGMH. But born actually in IGMH, live births were that. And then it comes to 2,105 when I counted the number of babies who screened. So why is this increasing? Where is this? Probably those are the referrals actually, because IGMH being a referral center, so there would be more children coming in it. So that must be the disparity in the counts. So after this, what is the achievement that we have gotten? Actually, no baby with the critical congenital heart disease have been missed in IGMH. We can proudly say. So is this being achieved in the other centers too? This has to be looked up to. And then is all the babies being screened or not? This has to be looked up to. There are many things in the pediatric cardiology we can do. Like we can screen these children actually in intrauterine life too. But they have to be, the manpower had to be trained. So being an only person, I would not be able to screen all these children's hearts intrauterine. But of course, all our radiologists are trained for a good anomaly screen. The baby's heart should be looked into in detail. And if they feel that it's abnormal, it should be referred for a detailed echocardiography. And we have had trainings from 2016 with the team from Bangkok and Amrita training our radiologists for this. And then many of the conditions are detected intrauterine too. So let's look at some of the congenital heart disease in the Maldives again. So up to 2019, you can see a vast variety of congenital heart disease again. So there's more than 1,000 cases registered only in this data is from the Eco Lab actually, from the work that I do only. And the new cases of congenital heart disease can be actually driven out of the data. How many children are suffering from it? So some of the crude data that I have done, actually with the help of my clinical assistant, I'm not a data analyst actually, I need help in that. So this is the forum which can open it into it, to look into these data actually. So these are done with the help of my clinical assistant who is there in our spare time. And then these are the newly diagnosed case of congenital heart disease in 2018. You can see that in that short time even we have 130 children with congenital heart diseases. And in 2022, A total of 81 cases. That is from September to December only. The data is for a short period of time I've been able to analyze. But of course, the rest of the data is there in the database, and then which needs to be analyzed. The newly diagnosed cases of congenital heart disease in 2023, you can see that it's so less because I'm not being able to do it. So that motivation has to come from somebody. Okay, the research has to go on. Papers has to be written. We need to know. We need to find out what is happening. Why? Where are these children? How can we help them? How can we prevent this in our country? Is it preventable or is it not? We used to refer all these children for heart diseases to India, nearby center, a very established pediatric cardiothoracic department and a pediatric cardiology department is there in Amrita, and all these children are referred there to Amrita, Kochi, and I'm somebody very biased because I am the one who actually looks after them as a pediatric cardiologist, even if you're 40 years with congenital heart disease, even if you're 50 years. So if they don't do a good job, the child suffers. So it is me who has to struggle with the child. So if you don't do a good job. So we did not have the cardiothoracic setup in IGMH. So these children were being referred to Kochi, I have to say, unfortunately. And we face a lot of challenges. I always praise my medical officers for the beautiful job that they do in transporting these critical babies. You can't even imagine how sick they can be. They would be intubated with a tube. And you would be having to bag the baby, actually. You have to give your oxygen with your hands. Imagine the time that the baby, you would be spending with the baby. In our airport itself, you have to keep on waiting. What if the flight gets delayed? What's going to happen to him? There is a very less space on board. You should imagine how difficult it's going to be. What if the batteries fail in the infusion pumps? What if the critical medicines that you are giving doesn't get delivered? So there's a nurse, there's one of our medical officers who I will say you're the best champions because these children are being transferred to India so beautifully that they have a normal life. So that is the achievement that we have. And then after that, they always tell me that, Dr. Eleena, that is not the end because I never traveled with any of these babies. I just tell them what has to be done. They are the people who do that. And imagine the rest of it is becoming even more difficult because the flight is up to Trivandrum. And then there is land travel. So you can imagine they're taking this critical baby in that condition to the tertiary center for the operation. And then, of course, in the waiting, in the referral center, what happens to baby? Are they being transferred to the CCU immediately? There'll be a waiting time everywhere, of course. So those are the challenges that we face. So with this, of course, the government came up with the National Cardiac Center, and then we are blessed to have it from 2016. And our adult colleagues started doing many interventions. Should be proud of them. So many of the adult heart disease is totally different from pediatric heart disease. I'm talking of the pediatrics, and then what you usually see and hear are the adult heart disease. But that is not what we should look at. We should look at the children. They are our future. We should look at them too. So in IGMH, many interventions are being done. But is pediatric cardiac interventions done? Actually, it's difficult to do it in the center that I'm working in IGMH because there's no pediatric cardiovascular thoracic backup there. Till today, we do not have cardiothoracic surgery backup in IGMH. So all the surgeries are done in ADK only. And but of course, the CVT services is just 20 minutes away. Being a small country, you should know that. So we have one setup in ADK, a very good setup. And then, but these pediatric cardiac interventions can be done in IGMS too. So with this new goal, again, I try to see whether we can achieve another level, another step. But should I take this extra mile or not? I do not know. I took it. So in November 2022, we even started pediatric cardiac interventions in the Maldives. So we collect the children, and then we have to wait for a certain amount of time. Of course, being a small country, we don't have these devices available in the country. We have to order them. So a lot of challenges are there. And we started the pediatric cardiac interventions. But of course, it was in ADK with Dr. Shafiu's team backup that I was being able to do this. So still, if I have to do it, I still have to work with their team and do it. Because if any of the complications occur, he would be the person who can help us. Me not being a surgeon, it's a collaborative work with the cardiothoracic surgeon. So this is one of the babies that I've mentioned that it is critical pulmonary stenosis, so balloon dilatation was done for that child. This is an AST closure where there was a hole in the heart and it was closed. And we have been able to achieve many things. But I would like to stress on this, especially the COVID-19. All of us would remember the time where the lockdown was. So during the COVID-19, so these forums, actually the main base has the topic has come to this. But I just wanted to keep it at the last. So during COVID-19 pandemic, where there was strict lockdown, there was a 10 days old baby who actually passed this critical congenital heart disease screening and was discharged from the hospital at 4 days of life. And there happened to be an incidental finding of heart murmur, which is the reason why majority of the babies come to me. And then, of course, it was nicely written. For the students, I would like to stress, the following babies was written there. Actually, the child had severe upper limb hypertension. The baby was discharged home. So when I saw the baby in the echo room, by the way, is in Dharmavanta Hospital. It's very extremely cold. So I usually don't expose all these babies. The mother was beautifully holding the baby with a soother, nicely wrapped. But when I saw the baby, I could not see his descending aorta. So that is the main artery which supplies to our body. So from the left heart, from the left atrium and the left ventricle, the blood is pushed into the aorta. So then it goes to the arms, the brain, the body, everywhere, actually. So that is how the heart works. Heart is a pump which actually deoxygenates the blood. Deoxygenated blood is oxygenated and pumped back to the heart. So it's not only the coronary artery which matters or the heart attack which matters. This matters a lot. So this was him. I've gotten the pictures from the parents with permission. Thank you so much for that. So I've shown you the normal heart, how beautiful it looks. But look what was there in this baby. And we did not know when the baby was sent home. Okay. So his aorta had a severe narrowing, actually. A severe narrowing. So when we admitted the baby to the NICU, the nurse called me and said that I was, of course, busy with the other patients in the outpatient department. I said that, Dr. Eleena, I could not get the blood pressure in the lower limb. The child had acidosis. So he was going to die if we could not help him. But of course, you should all remember that this is the COVID-19 time. It was locked down. And I have told you that we refer all the babies abroad. So, but this baby did not have that. So this was how critical it was for him. So let's hear from the audience. I'm sure many of us have children or brothers or little sisters and all. So let's say that this is your own little brother or little sister or your own child who was brought in this condition, in this day. And it's going to be the first time in the Maldives because many of these challenges occur because it is the first time. Nobody wants to be the first. So who would want their child to have that surgery that day in Maldives? A lift of hands, please. You are in the shoes of the mother or the father. Who would want to have that surgery? Okay, I have one hand up. Okay, all of you. Why is that? Because you're not being able to get referred to the abroad, or is it because you have confidence in our team? That question, please ask yourself. Okay, yes. Okay, so Dr. Umar is going to have the surgery in Maldives because that is the last option, actually. And he doesn't have any other choice because you cannot go to India because it is the COVID-19 time, right? Anybody else with a different answer? Confidence, beautiful, only one hand. But majority of us would not want that, actually, would not want it. So I told the mother, of course, if it is my baby, even I would have the surgery here in Maldives because he's going to die if he cannot do it. Okay? Because that is the last resort that we have. And then I have told you that we do not have this option in IGMH. We don't have cardiothoracic surgery backup in IGMH. So who are my heroes that time? Of course, Dr. Shafiu and Dr. Kaushal, the cardiovascular thoracic surgeon, I've told you. They were it. I am their eyes. I detect all these children, but I'm not a surgeon. I can do the procedures on a, not on an open heart, on a closed heart. I can close the holes in the heart. I can do many things, but not with an open heart. It's a surgeon who does it, along with us, the pediatric cardiologist. So I called up to Dr. Shafiu, who was, of course, who is beautiful, a person, a very positive person, I would say. And I explained, Dr. Shafiu, we have this baby with this condition. You are the only person that who can help me. Please, save him. You know the answer that he gave me. He did not hesitate. He was actually busy in an operation. When I called him also, he was actually operating on a mitral valve. He was replacing the mitral valve of an adult. His nurse, actually, because I kept on calling because this baby was suffering. And then his nurse put him on speaker and said that, yes, Dr. Eleena, we can do it. You come and stay behind me. That is what he told. That is the exact answer he told me. I will do it for you. You come. So we agreed on it. We explained to the parents. So this is how it's going to be. So that was the beginning of pediatric cardiothoracic surgery in Maldives. And because of COVID-19, I would say, we got everything ready. We have a beautiful team there in ADK, of course, led by Dr. Shafiu and Dr. Niaf, Abdul Niaf. And then everything was arranged. It was the first time, of course, in the Maldives. Everybody was stressed up. And then we shifted the baby to the OT early in the morning at 8 a.m. Of course, Dr. Shafiu started, and you can imagine, do you know the size of a small pediatric heart? How big is it? When we talk of this simply, how big is it? By the fruit shape, exactly, yes, a bit smaller. Yes, that is how big it is. So it's going to be the size of a strawberry. Okay, a small strawberry. So that is the challenge that we have. Okay, we can say this simply. So Dr. Shafiu opened the heart, and then it took a long time. It was the first time for him too. And then you know what he told me? He told me, Dr. Eleena, there's no coarctation. I diagnosed the case. Can you imagine what would happen to me? It was the first time which is happening, but luckily I was trained very well. I was trained very well, and I'm proud of it, actually. So I believe in teaching. And then I believe that everyone has that potential to do that. And he told me it's not there, because the pediatric heart disease is, again, different, I've told you, because it is not the adult heart that you have. It's totally different. You have to understand the anatomy. You have to see what is there. And I said, Dr. Shafiu, it cannot be anything else. Everybody was staring at me, Dr. Niaf, all of the anesthesia team, everyone. There was pin drop silence. The baby's heart was open, actually. I said, it cannot be anything else. I'm telling you, it is after beyond the third branch, 6 millimeter away from it, it'll be there. You search for it. And he said, and the hole that he has opened is this side. And he said, Dr. Eleena, you look at it. I said, I can't see anything out of it. It's so small. And he said, you scrub in and come in. So I actually scrubbed into this case. And then I asked him to show, and then this is what we found. Of course, he had the critical coarctation, and it was so small and so narrow that it cannot be repaired end to end. It cannot be joined, actually. It was so small. The aorta is the main artery which pumps to the whole body. All of us should realize that. So that's around 1 centimeter in a full-term baby. This baby was 2.6 kilo, so it should be around that. But it was so small that he couldn't even identify it. It was so narrow. There was no blood flow to his lower limb at all. It was totally cut down. And then it was repaired with a patch, of course, because we could not get enough material from the heart because he's so small. So a patch was used, and half of the aorta was patched up, and that is how they do a patch aortoplasty. So it was repaired nicely. And then you can see he was actually saved by a mere millimeter. Any of the students know how big this yellow cannula is? How many French is it? Students, the basics, yes. How big is it? The external diameter of a yellow cannula. Anyone? It's okay. Tell me. How big is it? 1 centimeter, 2 centimeter, 1 millimeter, 2 millimeter. How is it? 2 millimeter? Hands up. Sorry? It is less than 1 millimeter, yes. It is 0.7 millimeter. Actually, barely a yellow cannula was what we can send through his aorta. That narrow it was, actually. It's just to show how small it was, how critical the condition is. So I call this the positive side of COVID-19, of course. Because of this, Dr. Umar decided to have the surgery. And then many of you probably would have decided for it. All the hands that I saw up here must be because of that, I would say. And this is him on day 10 of surgery. He was ready to go home. After surgery, he was extubated beautifully. The procedure was, of course, long. We got out of OT by 5 or 6 p.m. in the evening. He was stable, and those are the proud parents, so happy. And this is him at 2.5 months post-surgery. So happy on one of the follow-ups. And then he didn't have much of a residual coarctation. It was beautifully repaired. It was beautiful teamwork, I would say. And this is him stepping up to a new milestone. So they're very close to me, actually, the mother especially. And she would keep on sending the photos. I'm so thankful, and she's wanted me to share this with the audience here. And this is him, actually, now, currently. This is how happy she is. Just a normal life he's living. And then if we had missed him, we would have lost him. And then we all wish him a very blessed life. And then may he stay happy and without any complications. Till now, he doesn't have any complications. So I thought this was the best forum to share it and then see what happens to these children. These are all areas of research. What happened to these children? We need to follow up. And after that, we have had multiple surgeries, congenital heart disease repairs in the Maldives, pairing up with the team in ADK. And they are all doing well. So we have to see the morbidity and mortality of these. So many areas in pediatric cardiology which has to be researched, which has to be looked into why we have all these problems. So with that, I would like to end that thanking Theveli again for bringing us all together and giving this opportunity for me. I would like to give a special thank to Dr. Shehnaz, of course, who was the person, and my apologies to Dr. Rahima, because I know how she would be thinking, why did Dr. Shehnaz give this topic to such a difficult person, because I hardly can take up the phone when she rings up. I was not being able to give the topic, actually, because I came down with a flu. I was not well. I will be in a conference when she rings up. And finally, actually, she came up with a topic during a conversation that we spoke of. Actually, I thought that because of them only, I am here today. And then this opened up because of them. Thank you so much, MNU, for giving this opportunity. And I'm sorry that I have mixed up both the, I was given 2 sessions, actually, and because of my schedule, I was not being able to do both, so I mixed it up, actually, because I thought this, I'll keep it as a workshop, which I have mixed up. Of course, Dr. Rahima did not give me that opportunity because I was too late. And apologies for that. I'm really sorry. I'm really, really sorry for that. Thank you all. And of course, special thanks goes to, where's Dr. Shahu? There she is. Of course, she would know how difficult a person I am too, because she gets through me. Bridging these boundaries is so difficult. She gets through me, through my little sister. Thank you so much.
Sorry for the technical glitch. Thank you, Dr. Eleena, for the very insightful and informative session on a very successful cardiac surgery. The floor is now open for questions from the audience. While we are waiting for the questions, I'll introduce myself. My name is Shiza, and I'm the Dean of School of Medicine, and I'm the moderator for this session, as you would have already known by now. Any questions from the audience?
Thank you, Dr. Eleena, for your excellent journey and the contribution for the community. I'm Dr. Zeba. I want to ask actually about when you are screening one case, and I'm telling it as a case, and after addressing the case, like medical treatment or surgical treatment, how many years you do the follow-up, and is it, you say that it is scattered in whole Maldives,
Of
and
course,
yeah, yesterday we talked about it.
Yes.
So I'm targeting to the data, like whether it will be data under Asanda or IGMS, or how you are taking those things. Is it in a one umbrella, or we have to find out it?
Thank you, Dr. Zeba. That's a good question. Actually, this is compiled. I just have an Excel sheet, actually. I've collected it all, every child who comes into the eco lab. All these data that I've shown is just from that Excel sheet. So a lot of data is there because I'm somebody who loves research. So I thought that I would tabulate them at least so that we can use it. So every year, I have a different sheet. So I monitor them. And of course, they come for follow-up. How long follow-up? I've been in the field for 9 years now. So we would have the follow-up data for 9 years, if you look into it, if that is.
Sorry, the first patient, if you see, still he or she is under your follow-up?
Yes, being
Wow.
an only person, actually,
Excellent.
yeah, they don't have an option right now.
Yeah.
So
Now again, I will look at Dr. Rahima. Inshallah, we can do some work with this, inshallah.
That is what the whole reason for this seminar. Yes, thank you.
Thank you. I actually wanted the mic to thank you for this inspiring presentation.
Thank you, sir.
Really enjoyed this and very well done. Thank you very much. And the question I have is that what's the percentage of live births with heart defects in the Maldives? You may have shared it in America.
Yes, I have. Actually, it comes so high, I haven't shared the data, actually.
Yeah.
So it's actually 1 in every 100 child has a heart disease.
Okay.
But our data shows it's much higher, actually. It's 5 to 6. So we have to validate it. We have to see. Because being an only person, I'm just wondering whether they are pooled up into one center. So is that the reason? I have no clue, actually. So we'll have to look at it. So we'll have to discover, because it comes very high, extremely high in Maldives. Yes, but in the Western data, and if you look at the global data, it's 1 in every 100 children. Live
Regionally,
births.
it's the same, right?
It is, sir. It is.
Thank
Yeah.
you again. Excellent presentation.
Thank you, sir.
Yeah.
And thank you for giving this opportunity again.
Thank you, Dr. Eleena. Can we go back to the slide where you showed the guideline,
Yeah,
national guideline?
yep.
I wanted to ask is whether the national guideline is followed throughout across the country, especially in the hospitals in the atolls, rather than just in IGMH and the tertiary hospitals in Male. And have we done an analysis of that from the time it has been released till now? Because this is 2018.
Yeah.
So, yeah.
Thank you, Dr. Malik. That's a question that I should ask the Ministry of Health,
Ministry
actually.
of Health, yeah.
Of course, the Ministry of Health, of course. We've gathered everyone from the regional hospital too. So there would be people who are trained. This protocol is available online. So it should be done, but unfortunately, actually, the truth is, we cannot even we cannot take a saturation of the babies in the islands, actually. We do not have the pediatric probes. That's the truth, actually. That's true. I have been trying as an only person. It's difficult, but I have tried. I said that we cannot measure the saturation with an adult probe, which is available everywhere. Yeah. So the baby, when they are flown in through Asanda, of course, they'll be having a big probe, which will be falling off their small toes and fingers, it not be accurately detecting it. So no, so this data would not be available
But
there.
at least they are trained.
They are
on
trained.
this.
There should be a person, and this is very simple to follow. So it's doable actually, because my mentor has covered the whole of Thailand. So why would we not be able to cover this small place? That is what I feel. That is what I told. And he said that, Eleena, you can do it. I have done it in whole of Thailand. So that is the inspiration that he gave me. So I started it with this, but only in the Malay.
Thank you.
For now.
Yeah.
A question from me, Dr. Eleena.
Yeah.
I was wondering, as audience, they would probably like to know whether there are predisposing factors for congenital heart diseases, and also what can they do to prevent this kind of an abnormality in the child.
Thank you, Dr. Shiza. That is what I want to look at. By observation, I can say, but of course, that is an expert review, which is the lowest evidence, of course, you can say. A lot of maternal diabetes is there. So if I do 10 echoes, I would say that 50 or 60% of them is because of gestational diabetes. So that can be one reason, actually. So of course, our population being the healthy habits, actually. So that is one of the contributing factors that I can observe. But of course, we have to look into it in more detail. I'll not be able to say why, but it is a lot of heart diseases there in our community.
You mean diabetes during pregnancy, right?
Yes.
What if
Gestational
the sugar level is controlled and during the pregnancy, even if the mother has diabetes, will it still be a predisposing factor?
It is one of the identified risk factors for congenital heart disease, maternal diabetes. Whether gestational diabetes is one, of course, maternal diabetes it's similar. Just one factor, actually, but which is very common. How can we prevent it? Yeah, but we need, again, collaborative work with the public health. We have to control diabetes. We have to have awareness sessions. It can be doable with the Department of Gynae and Obs, with the public health team. And I think this is achievable, because it's so disheartening to see majority of the moms being diabetic during pregnancy, and then I have to see the heart just to see that the baby has a heart disease or not. It is preventable. In this small society, I think this should be done.
Thank you.
Hi. Kind of following up on the early detection screening aspect, so the radiology, I guess in that domain, is there any intent or ability to integrate machine learning into that process so that some of the technical limitations on the ground, like capacity limitations on the ground, is kind of overcome?
You mean for the intrauterine detection?
Yep.
For the intrauterine detection, many of our radiologists are trained to do the basic screening of the heart during the anomaly scan. And of course, yes, that needs a good machine, which we have in the IGMH. But I'm not sure in all the clinics and all, but this has to be a high-frequency probe, because the heart's going to be even smaller intrauterine. So you have to see all these details that are shown. So it's going to be challenging. But in the IGMH, of course, it's doable. But it takes a lot of time. It takes, for me, I have to free up 1 to 2 hours of my time to do a detailed fetal heart, fetal echocardiography, actually. So it depends on the baby. Doesn't stay put intrauterine. They're free to move. They'll keep on rotating. As soon as I find the heart, okay, he'll decide not to stay in that position. He'll turn, and the spine would be anterior. So again, I have to give them time. They'll have to rotate. So it needs certain things, and of course, a lot of time and a good machine, yes.
So, Dr. Eleena, you mentioned that you have a lot of data on this, and we have seen a lot of research, especially done by the medical students from medical school that in different areas, and very nice and excellent research they have done. So, I was wondering whether any of the medical students approached you with to do any research on this?
Thank you, Dr. Umar. Actually, no, not till today. I hope it changes actually after this session. Let's hope
So
that it
yeah,
changes.
hopefully our Dean of School of Medicine is also here. So probably this is an opportunity for the students to do research.
Yes, Dr. Shiza. Yes, of course. There's no study in congenital heart disease in the Maldives which is published. No, all my researchers, they are from, of course, cases from abroad when I was doing my studies, which are published in, thanks to my mentors, in very high-level journals, actually. So I believe in a lot of research. I studied in an institute which is actually very research-based and focused. Institute of the institute, it's the National Regional Dengue Center is there, Queen Sirikit National Institute of Child Health. So they have a very good research team there who helps us actually. So we don't have to go finding for a statistician, which I am not being able to do here. So of course they would provide me with that. They would tell me if I do anything wrong with the data collection. They would tell me that you have to collect it in such a way that it can be analyzed. So they guide me through it. So that is how easy it was for me there. But of course, the ethics committee, here we have a lot of barriers that we have to cross. Of course, Dr. Shiza would be annoying. And I hope that this breaks the barriers, and then we can bridge it up, and then find ways to do this. Dr. Shiza, yes.
Thank you, Dr. Umar and Dr. Eleena. During the sidelines of this conference, actually, we have had a bit of a discussion regarding research on congenital heart disease and our students' research. So we will be approaching Dr. Eleena very soon to continue with the research suggestions she has advised for the students. Any more questions? We have about 7 minutes remaining. Maybe, Dr. Eleena, I was having a look at the graphs you showed,
Yeah.
and atrial septal defect is the commonest we have. How many of these cases are we able to repair
In Maldives.
in Maldives and also abroad, if you would like to enlighten us on the cases?
Thank you again, Dr. Shiza. If you look at the congenital heart disease, the ventricular septal defect, which it is the most common heart disease in the whole of pediatric heart diseases. ASDs, it's common seen because these are screened initially at birth. So all of the children actually, they have 2 holes in the heart when they are born. So when they are born, all of us has those holes in the heart, and they have to close at 3 months follow-up, and if it doesn't close, then only actually it matters. So majority of the atrial septal defects, they can close spontaneously actually within 3 months, 6 months, or even 1 year. So this data is collected whole through the database, so that is why it's showing high up. And this is the simplest form of heart disease, which can be easily repaired without opening up the heart. I myself can do it. I'm trained for it. And then Dr. Shafi, of course, if it is not a devisable case, Dr. Shafi is there. So these are simple cases, and they would have a normal lifespan like anybody else who doesn't have any heart disease. You would not know that a child has heart disease actually with this. Because they don't have any symptoms. The symptoms even come up at the age of the students maybe. So that is the age they come up with the symptoms during pregnancy if it is a girl, or during adolescence at 16 years. So they go undetected, but this is so high because this is screened at birth, I would say.
Thank you.
Assalamu alaikum. I'm Amna Triyaz. I don't have a question, but I just wanted to say that how thankful I am. I'm a mother, and I can understand the feeling, so I can understand how thankful the parents must have been. And I just wanted to thank Dr. Eleena for all the work that you are doing. My youngest child was put in NIC, so I understand that feeling, and your talk actually made, I think, many of us cry a little bit inside. Thank you.
Thank you so much. Yeah, that's so inspiring.
Thank you, Dr. Eleena, for a wonderful talk. I'm Dr. Eugene. I'm a forensic pathologist. I'm a forensic pathologist from Nepal, and we see some cases that are undiagnosed, and here it's easier because of Asanda.
Yeah.
So here, considering the context, what are some of the factors or some of the issues that parents face with regards to congenital heart disease here in the Maldives?
Thank you for the good question. In the Maldives, actually, I would say, like, I studied in Nepal too. So I know the context there and the context here. We are so blessed to have the Asanda system, actually. So in the Nepal, they do not have this setup. A lot of children die there. There's only Shahid Gangalal Hospital, which is the referral center, and they do not even have the pediatric cardiac thoracic surgery till date, I would say. Actually, interventions can be done there in Nepal. But so we have reached a higher level, I would say, in this, because our collaborative work is done. Dr. Shafi, who is trained in pediatric heart, though he's an adult cardiothoracic surgeon, so he can help with that. But in Maldives, yes, the challenges that we have are because many of the complex heart diseases we are not being able to do here because we do not have the setup for the cardiothoracic surgeries in the Maldives. We do not have a pure pediatric cardiothoracic surgeon. Of course, these subspecialty fields, nobody would want to come and stay in a small place like us because less cases are there. So that is one of the challenges because we've asked to get a pediatric cardiothoracic surgeon for a long time, maybe 4 or 5 years. But nobody actually is interested, I would say, with the small caseload here, with the salary scales. Many factors would be there. So that is one of the challenges here. And the parents find it, the convincibility. I would say that it's very difficult to still convince them, actually. Many of the parents would say that they would get the treatment here, and the last minute they would change their mind. So that has to be brought into. So those are the challenges, of course, but Asanda helps, and then Asanda is actually a difficulty in some way because they have an easy channel to go abroad, I would say. So we can actually talk both ways. So it's an easy decision and a difficult decision, both for the parents because of this.
Okay, thank you, Dr. Eleena. I would like to invite our Vice Chancellor, Dr. Shehnaz, now to give a small token of appreciation to Dr. Shehnaz. Dr. Eleena, sorry.
So much. Thank you so much for giving this. I'm sorry for being so difficult. Thank you, Dr. Enas. Thank you all.
Thank you, Dr. Shehnaz. Thank you, Dr. Eleena, once again for sharing your insights and experiences with us today. Your presentation was truly enlightening. The advancements and the education of the case you have highlighted are both inspiring and was invaluable and to the medical community and to the public as well. It shows that Maldives has taken several steps in advancing medical services. We are deeply grateful for your contribution to this conference. That concludes our session for today. I want to extend my
Thank you, Dr. Ashiza, for that beautiful words. කලනුරේ හස්තයිතක මිය කොපෙහිරවල් බාවරචි එමෙ සිමිලා වේදාන්ති වතාස් එදින